My name is Jonathan Hill. I'm talking to you from London, and I'm joined for this webinar by my friends throughout Europe for a discussion about the DISRUPT CAD III data, the implications for Shockwave, and how we're going to be developing our calcium modification practice. I have Carlo Di Mario from Italy, Flavio Ribichini, also from Italy. We have Holger from Germany, and Margaret McEntegart from Scotland. We're going to be taking you through the DISRUPT CAD III data. We're going to be presenting data from the OCT sub-study, and we're going to be having a broad-ranging discussion about some of the specific aspects within the CAD III study. We're going to be talking about the use of intracoronary imaging, the learning curve with Shockwave, how we integrate IVL into our other calcium modification strategies. We're going to be talking about the safety of the study, and we're going to be delving into some of the nuances of treating eccentric and concentric calcification. So it really gives me a great pleasure to be able to give this webinar now in the knowledge that the DISRUPT CAD III data is about to be published. So on December the 1st, we will be publishing the data in the Journal of the American College of Cardiology. And those of you who were able to attend the virtual TCT, so TCT Connect, will have seen this data being presented by Dean Keriakis. Dean Keriakis is based at the Christ Hospital in the USA and was the co-principal investigator for the study. It really was a testament to the investigators and also to the Shockwave team. Shockwave Medical really put together an outstanding trial group chaired by Greg Stone, and the study was completed just at the beginning of the COVID pandemic. And really, it's a remarkable feat that we've now processed all the data and it's now being published. So I'm now going to introduce myself, giving the DISRUPT CAD III data presentation. These are the slides that were presented at TCT, and this is all of the data that was presented for the manuscript, which is being published in a couple of weeks' time. So over to me in the studio, and if we can cut to the DISRUPT CAD III presentation. The CAD III study design is a prospective, multi-center, single-arm global IDE study performed in 4 countries: the US, UK, Germany, and France. Patients with heavily calcified de novo coronary lesions were enrolled. This definition includes radioopacities on both sides of the vessel extending at least 15 millimeters in length by angiography, or a calcium angle at least 270 degrees by intravascular imaging. Reference vessel diameters had to be 2.5 to 4 millimeters, and stenosis severity had to be at least 50%, and lesion length had to be 40 millimeters or less. 1 roll-in patient per site was allowed at 47 global sites. There were 47 roll-in and 384 patients in the intention to treat population. The primary endpoint was assessed at 30 days, and there was a 100-patient OCT sub-study. The primary safety endpoint was freedom from MACE at 30 days, and MACE was defined as cardiac death, myocardial infarction, or target vessel revascularization. The primary effectiveness endpoint was procedural success, defined as successful stent delivery with residual stenosis of less than 50% without in-hospital MACE. Key secondary endpoints are shown and include procedural success with a residual stenosis less than or equal to 30% and no in-hospital MACE to allow a sensitivity analysis with a more contemporary definition. These are the key clinical and angiographic eligibility criteria, They include being biomarker negative, having an ejection fraction greater than 25%, single de novo lesions with a stenosis greater than 70% but less than 100% were included. If the stenosis was at least 50% but less than 70%, there had to be objective evidence of myocardial ischemia or an FFR measurement of less than or equal to 0.8 or a lumen area of less than or equal to 4 millimeters squared by intravascular imaging. The exclusion criteria included renal failure, defined as creatinine greater than 2.5 or dialysis, and myocardial infarction within 30 days. The pre-specified performance goals for this study were based on the rates from the predicate single-arm non-randomized Orbit-2 IDE study for orbital atherectomy, which enrolled similar patient population with similar endpoints and definitions. The relative risk of 1.5 was utilized per FDA guidance. The primary safety performance goal was calculated as 100% minus 1.5 times the observed 30-day MACE rate of 10.4%. And the primary effectiveness performance goal was calculated at 100% minus 1.5 times the observed procedural failure rate in Orbit-2 of 11.1%. This study is over 80% powered for both co-primary performance goals at a one-sided type 1 error rate of 5%. I want to acknowledge and thank the CAD III study support infrastructure, including my co-PI, Dean Keriakis, the study chairman, Greg Stone. The clinical events committee was chaired by Steve Marks. The DSMB was chaired by Etisham Mahmood. And the angiographic core lab directed by Maria Alfonso, and the OCT core lab directed by Akiko Mahara. They all did an incredible job. Most of all, I want to acknowledge and thank the top enrolling centers and the site principal investigators as shown here. This group did a remarkable job to bring this trial to completion in the face of COVID-19. Patients were enrolled from January 2019 to March 2020. A total of 431, which included 47 roll-in and 384 in the intention to treat population. The completeness of follow-up is shown. There was only one patient lost to follow-up and 2 deaths. These are the baseline clinical characteristics. The average age was 71. 90% of patients had either hypertension or hyperlipidemia, 40% had diabetes, and 26% were defined as renal insufficiency using an eGFR of less than 60. As you can see on the right, 70% of patients had class 2 or 3 angina. These were the baseline angiographic characteristics, including a baseline reference vessel diameter average of 3 millimeters, lesion length average of 26 millimeters, and a calcified segment length of 48 millimeters. 100% of these target lesions were classified as severe calcification. These were the procedural characteristics, which show that 50% of the targets were predilated with a 2 millimeter or less balloon. An average of 69 IVL pulses were administered per case with a maximum IVL balloon inflation pressure of 6 atmospheres. Over 99% of stents were successfully delivered. These are the angiographic outcomes on the left. You can see the stepwise reduction in severity stenosis from pre-procedure to post-IVL and final in-stent. And on the right, the stepwise increase in minimum lumen diameter at the same time intervals. A diameter stenosis of less than 30% was achieved in 99.5% of patients. These are the angiographic complications noted as post-IVL and final. As you can see, severe dissection type D through F was observed in 2.1% post-IVL. This was reduced to 0.3% following stent deployment at the end of the procedure. Note that perforation, abrupt closure, and no reflow were 0 post-IVL. These figures at the end of the procedure were 0.3%, 0.3%, and remained 0 for no reflow. The primary safety endpoint, freedom from 30-day MACE, was observed in 92.2%. The lower confidence boundary of 89.9% meets the safety performance goal. The primary effectiveness endpoint, stent delivery with residual stenosis less than 50% and no in-hospital MACE, was observed in 92.4%. Again, the lower confidence boundary of 90.2% meets the effectiveness performance goal. This slide shows the in-hospital and 30-day MACE of 7 and 7.8% respectively, along with the individual components. Key secondary endpoints included device crossing success, angiographic success with a less than 50% residual stenosis, angiographic success with a less than or equal to 30% residual stenosis. All of these were 96% or greater. Procedural success with residual stenosis less than or equal to 30% was 92.2%. On the left is a diagnosis of periprocedural MI using 3 definitions per protocol, Fourth Universal, and SCAI. None of these definitions altered the primary conclusions of this trial. And on the right, you can see the target lesion failure was 7.6%, all revascularization was 2.6%, and stent thrombosis 0.8%. IVL ventricular capture has been noted before this study, and in this study demonstrates that 41% of patients had some evidence of IVL-induced capture. It was significantly more common if the pre-procedure heart rate was lower, particularly by multivariate analysis less than 60 beats per minute. The drop in systolic blood pressure was more frequent, but as you can see, not more severe based on this analysis, and there were no significant sequelae. With the introduction of any new technology, there's a learning curve. This slide compares the 47 roll-ins, which was the first case for each of the 47 international sites, compared to the 384 patients in the pivotal study. These two groups were similar with respect to clinical and angiographic characteristics. And as you can see, their key outcomes, 30-day freedom from MACE, procedural success, even device crossing success, were similar. In conclusion, I'd say that the success of the DISRUPT CAD III trial was achieved, as both the primary safety and effectiveness endpoints were met following treatment with coronary IVL in severely calcified lesions. Coronary IVL prior to drug-eluting stent implantation was well tolerated, with low rates of major periprocedural clinical and angiographic complications. Transient IVL-induced ventricular capture was common, but was benign, with no clinical sequelae in any patient. And although this study represents the initial coronary IVL experience for US operators, high procedural success and low angiographic complications were achieved, reflecting the relative ease of use of IVL technology. Thank you for your attention.
Okay, thanks, Jonathan. I'm Margaret McEntegart, a consultant cardiologist at the Golden Jubilee Hospital in Glasgow, and I'm now going to talk to you about the DISRUPT CAD III OCT sub-study. So the presence of calcium in the coronary arteries is increasingly prevalent and problematic when performing PCI. This can impair your device crossing and delivery. It can cause delamination of stents and ultimately result in underexpansion of your stents and poorer long-term stent outcomes. Intravascular lithotripsy, or Shockwave IVL, delivers acoustic pressure waves up to a pressure equivalent to 50 atmospheres, causing superficial and deep calcium fractures, as you can see from this animation. The coronary IVL DISRUPT program now consists of 4 trials, and what we're going to concentrate on here is the OCT sub-study of DISRUPT CAD III. From DISRUPT CAD 1 and 2 OCT sub-studies, we know that IVL can induce multiple circumferential calcium fractures, and ultimately in all these cases resulted in good stent expansion and stent outcomes. The objective of the OCT sub-study in DISRUPT CAD III was to further elucidate the action of IVL in these de novo heavily calcified coronary lesions. What was unique about the study was that OCT was performed at baseline, following IVL and following stent expansion and delivery. In the overall study population, there was 431 patients, including the roll-in population, 1 patient in each site. Within that population and the intention to treat population, 100 of these patients were included in the OCT sub-study, and that's the data that we're going to look at now. So looking at the baseline characteristics, the 2 things to note, as you might anticipate, is that the OCT patients were less likely to have renal insufficiency. They were also less likely to have had prior bypass surgery. If we look at the angiographic characteristics, you were more likely to have OCT if it was an LED lesion that was being treated, and less likely if it was a circumflex lesion. You can see that the reference vessel diameter, minimal luminal diameter, were both slightly larger in the OCT group, whereas the diameter of stenosis was slightly smaller. Now, the absolute values that were different between the 2 groups were very small and probably irrelevant. Looking at the procedural characteristics, of particular note is that the OCT patients actually had shorter procedures at 58 minutes, although this was not significant. This is obviously very interesting in the context of imaging and physiology often being associated with leading to longer procedure times, which wasn't the case here, allowing you to perform precision PCI in a timely manner. What you can see is that if you used OCT, you were likely to use slightly more pulses of therapy, and you were less likely to use predilatation, presumably because being able to cross the lesion with the OCT catheter gave you confidence that the IVL balloon was going to cross without any pre-treatment. So here's an example case from the sub-study. So you can see in the angiogram on the left, there's a severely calcified lesion in that mid-right coronary artery. And you can see from the OCT co-register image on the right-hand side that the MLA was 3.3 with a maximum calcium angle of 360 degrees and a thickness of over 1 millimeter. So the IVL balloon is delivered to the lesion, and you'll see as the therapy is delivered that the balloon starts to expand, improving vessel compliance visually. And you can see on the right-hand side with the OCT that the minimal luminal area at that spot is now increased to 5.8 millimeters squared. And you can see that there's multiple characteristic stepwise fractures in the calcium. Following stenting is very nice angiographic result, with the MSA increasing to 8.7 millimeters squared, and with the minimum stent expansion at 79%. You can see on the spin round, it's a nice symmetrical expansion of the stent. So looking at the serial OCT measurements from pre-IVL, post-IVL and post-stenting, you can see the MLA gradually steps up, as does the improvement in the diameter, the area of stenosis. You can see that the maximum calcium angle was 293 with a thickness of almost 1 millimeter. And you can see that the mean stent expansion was over 100%, which is excellent. This is a graphical representation of this stepwise shift in the luminal area gain. So you see pre-procedure, post-IVL, we get a step up in gain, and then a further step up in gain after stent deployment. 67% of the lesions had a fracture that was visible in the OCT, with a minimal angle at the fracture site of 192 degrees, which is consistent and in keeping with the recommendation to use a device for angles of calcium over 180 degrees. You can see from the graph on the right-hand side that following stenting, there was a significant increase in actually the width of the fracture. Interestingly, there were obviously a reasonable proportion of patients where there was no visible fracture seen in the OCT. So they went on to analyse visible fracture versus non-visible fracture, and what they saw that was in these 2 populations of patients, there was no ultimate difference in the MSA, stent expansion, or the final area of stenosis, whether a fracture could or could not be seen on the OCT. And the thinking is that this is most likely due to the presence of microfractures that the OCT can't detect. And this is some data from the femoral artery where they use micro-CT and histological samples, which shows this phenomenon of these microfractures that you can't pick up with the resolution of OCT. And the suspicion is that this is the same mechanism in the coronary artery, with an intention to go on and perform some analysis to confirm this. Looking at safety outcomes and performance outcomes, the device crossing success was 100%, procedural success 98%. You can see the angiographic measured outcomes are very good down in the left-hand corner. Looking at complications, there was no complications in the OCT cohort within the study. So in conclusion, OCT confirmed the safety of coronary IVL with no severe angiographic complications at the end of the procedure. It demonstrated both longitudinal and circumferential calcium fractures in these heavily calcified lesions, resulting in increased vessel compliance, large post-procedural MSA, and excellent stent resultant expansions. The MSA, area stenosis, and stent expansion outcomes were excellent regardless of whether a calcium fracture was visible in the OCT, with the current assumption that this is due to subtle microfractures or fractures out of plane that are non-visible on the OCT. So back to the panel now to discuss the data further and hear what everyone else's take is on the data.
Thank you very much, Margaret. So we're now going to have a panel discussion about this data. I'd like to come to Flavio first. Flavio, you're I think the chair or the president of the 4C group within Europe, the Euro-PCR group focusing on calcium modification. So I think you have got a long-standing experience with all forms of calcium modification. From your perspective, what does the CAD III data bring in addition to the European physicians?
Thank you, Jonathan, for the question, and hello everybody for meeting in this webinar together, following these fascinating presentations. What to say? No doubt that the most important addition that these studies provide to our community is the evidence of well-recorded and well-presented and well-analyzed scientific data. You know that we always look with enthusiasm and some curiosity new devices coming into the field, especially when they come to help in difficult scenarios like the calcified lesions. This was absolutely the case with the first comments we heard about the use of this new technology, and we are all curious of using and testing the device. So far as I know, the device is not very widespread in European labs. I, of course, have had the chance to use it, and you get really shocked by the simplicity of its use and the efficacy when you use it. But scientific data was missing. And so to answer your question, I think that the data you and Margaret have presented in the previous two presentations really reassure what has been the feeling of having a very important new player in our lab that has a lot of perspective to help our patients.
Mm. And are you reassured about the safety aspects and the efficacy of IVL? Is this sufficient data for you to change your practice?
Well, you know, to test safety of devices, you need hundreds and hundreds of cases for sure, because you never know when a complication is going to happen, even in the most expert hands. But the data that you have presented on over 300 patients adds to the previous two studies. So it's hundreds of cases. And it's overwhelming to know that in this difficult anatomy, you have 99% of stent delivery, which is one of the nightmares when you try to push your stent in a calcified lesion. And another data that I think really worth mentioning is 0% of no reflow or low flow, which is, on the other side, a quiet, I'd say very frequent, but a scary complication of using rotational devices, because these may create hemodynamic impairment and this makes your operators nervous. 0% is really much better than what I expected. And the third point that I think it's very reassurance is the lack of perforations. These are common complications in calcified lesions with any kind of devices you use. Even the simple use of high pressure balloons can complicate with perforation or even coronary rupture. The figures that you have shown are really, as I said, much better than I would have expected. And so the results are certainly reassuring. Last but not least, there is nothing like bar entrapment or these kind of difficult situations you get very, very nervous to get out of when you have a device-related complication. That, of course, reduces with time and with learning curve. But the slides you showed regarding the learning curve of these devices is the same you have with a normal balloon. So personally, I think that we are in front of a very promising new technology.
Thank you, Flavio. So coming to you, Carlo, you've been involved with this technology from the outset. I think recruited some of the first patients worldwide for the DISRUPT CAD I study. And I think you've also been one of the pioneers of the introduction of the peripheral technology for large bore access, particularly for TAVI. So my question, Carlo, relates to, you're an advocate for intracoronary imaging. In a real world setting, is intracoronary imaging required to guide calcium treatment?
Thank you, Jonathan, for your question. And nice to see London behind you. I've not been there for a long time, unfortunately, but hopefully it's going to finish in a few months with this nightmare of COVID. Well, I think you asked the question a little bit to the wrong person, because as you know, I'm quite biased, because I have to acknowledge that I tend to use imaging because I believe that when you treat complex lesion, especially, you will achieve better outcome. And you will all agree that calcified lesions are complex lesions by definitions. So let me first tell you a little bit my practice with imaging and lithotripsy, and then try to be as possible in answering your question. I believe that when you have moderate to severe calcification, it is always a good idea to put a intravascular imaging catheter out of the shelf. And I select OCT when I can, but of course, if you have CKD or if you are dealing with ostial right or ostial left main, you will prefer an intravascular ultrasound. That's basically my selection. I'll try to cross with that first, except in the most impossible cases, super long, super tortuous, rotablator sort of lesions. That makes no sense, I think. Otherwise, no matter how severe the calcification, you try, sometimes it goes through, and then there is no need for pre-dilatation, as your data have shown. Then you go straight with a lithotripsy after a balloon catheter, knowing exactly where the calcium starts, where the calcium finish. But I think the greatest advantage is when it's moderate. Of course, you can do a sort of bailout lithotripsy. You try with a balloon, doesn't inflate, and then you go with lithotripsy. But often you get away, you believe you get away, and then you embark yourself in a complex procedure unnecessarily. If you do your imaging first, you will know when it's 360 degrees, Napkins ring, long, complex, thick, and then go for lithotripsy. So that's my general answer. Having said that, I think there is something specific that comes from this beautiful study, and in particular from what Margaret showed us. The OCT sub-study was the first time that we had, 100 cases, not the 30 that we had in our initial 2 studies each, but a large series consistently acquired. And we have to admit, I try to use OCT as much as possible because I believe that more fractures meant better final outcome. Wasn't true, and we have to believe this.
Okay, so
very clear. So at this point, my answer is very clear. I believe that you can achieve safely and effectively an excellent expansion of the stent in a very calcified lesion without necessarily using intravascular imaging, and in particular without paying too much attention to presence of microfracture with OCT. As Margaret pointed out, they're always there. If you see an expansion of your balloon, well, you must have modified your plaque. The microfracture that has been shown with micro-CT by Vermani, I think, are a testimony that this is the case. So I think it's important in general to treat with imaging all complex lesions, but you don't need necessarily to associate intravascular imaging and lithotripsy, and believe you can do without.
Mm-hmm. Can I just, on this subject of fractures or not and the mechanism of action, maybe I could just come to Holger and Flavio. If you've just got some comments about this, the percentage of cases where fractures were seen, and then this perhaps newer concept of microfractures. Is this a plausible explanation for us not seeing fractures? Holger.
Holger, to go first.
Well, yes, I think that, of course, the microfracture story is part of the compliance issue of the vessel, and that the vessel can expand adequately. And of course, if you have seen the OCT pictures, it's quite astonishing how the microfractures occurs in these calcified lesions. And I think, yes, the story is true.
Mm-hmm. Flavio, what are your thoughts?
Well, very briefly, I really enjoy looking at these fascinating images. But when you put a stent, Jonathan, when you put a balloon on your lesion and you go up and you see the dog bone and it doesn't open, I really don't care about the fractures. I mean, at that point, either I take my rotabar or I take my IVL catheter. And when the balloon of the IVL expands, means that your stent will expand. So it's nice to see, it's nice to know, because it's a new technology and we need the evidence. But what is impressive of the technology is how effective it is in a routine use.
Okay, great. So coming to you now, Margaret, and I'm going to just come to you about a safety question, and it's really this phenomenon of IVL-induced capture, or shock topics, as we're now calling this. So, can you just give me your understanding about what shock topics are, and about whether they're associated with any serious adverse clinical events? And just give me your own experience when you first saw them. You need to unmute yourself, Margaret.
You think I'd know by now? So, as you quite clearly and nicely explained in your talk, Jonathan, it's this idea of you get this electrical and mechanical capture. Sometimes in some patients, you just see the electrical capture in the ECG, and sometimes you see the mechanical capture of the ventricle. And as you explained, more commonly in patients when the heart rate's slower, particularly if it's below 60 beats per minute. And with that, you often get this associated fall off in the blood pressure very transiently while you're delivering the therapy. That, as in the DISRUPT series of studies with no adverse events associated with either the blood pressure or the capture, and certainly in clinical practice also with the thousands and thousands of devices used worldwide, the data is very reassuring that this is a phenomenon we observe when we use it, but it doesn't appear to go on to have any significant adverse events in huge population of patients treated with the therapy. So, it's something you see very commonly when you use the device, but in use of it in everyday clinical practice now, very comfortable with it. I suppose it's like everything else at the beginning, you're slightly wary of what this is going to mean and how it's going to affect the safety, but I think we can be quite reassured now with the data that this is just a phenomenon we don't need to be concerned about.
Carlo, are you reassured about the data regarding shock topics?
Well, honestly, except seeing these minor pressure drops, is hard to really. I mean, it's important to know they exist. How significant arrhythmia have ever been described, and I think FDA has requested to have a close look to that. Now we have a fully well-documented, well-monitored trial. We can forget.
Yes, I mean, I think the electrophysiologists, when they first saw this, people didn't quite have the explanation, but I think now, I think people see it as a benign epiphenomenon. Yeah. Margaret, so back to you again. Just could you give me your feedback on the learning curve analysis from CAD III and your own experience of getting used to the technology?
So I think that as you saw from the study, and as everybody who's used this device in clinical practice knows, this is a balloon-based technology, and really there's no learning curve beyond delivery of the balloon across the lesion. And then it's really just about how you plug the machine in, which is very intuitive and very simple. So I mean, I think in the study there was one patient rolling for before the patient started to be included in the trial. So that in itself is an indication of how accessible the technology is. That you know, you didn't have to do a series of supervised cases before you were allowed to recruit patients in the study. So I think it's an incredibly simple and intuitive technology to use, and I think that's really the biggest advantage of it over all other communication technologies, how easy and user-friendly the device is.
Yes, I think the concept of having a Shockwave proctor is probably not required.
For sure.
Okay, thank you, Margaret. Flavio, you've used this device and are used to dealing with all the different calcium distributions. Do you think that there is a role for Shockwave in eccentric lesions as well as concentric lesions? What's your own personal experience?
I do think that it works, and if it works in concentric lesions, which are tougher than eccentric lesions, it will certainly work also in eccentric lesions. So I wouldn't make this difference as a criterion for selecting the device. I think that what Holger said is very important. When you have very tight lesions, either you predilate or you go with your rotablation device. Tight and very long lesions are the main indication to use your rotablation. And it might be very hard to push the balloon of the IVL in these lesions. As I said, two different indications. I don't make this big difference in between concentric or eccentric. I think the device works regardless of the distribution of calcium. And as I said in the beginning, it's probably the easiest way you can prepare a lesion for a nice result in the end.
So Holger, yes, we'll come back to you. Yes.
No, just to confirm, Flavio, of course, you have not to make any difference eccentric or concentric lesions. However, so you can apply the IVL in both the concentric and the eccentric lesions.
Margaret, can you just give me your insights? I mean, are you using this selectively for concentric, or are you mixing between eccentric and concentric? How does it fit into your own personal algorithm?
Yeah, I think this is a really, for me, the most interesting question around about IVL is how it affects the eccentric, is particularly the nodular eccentric, because obviously you can have eccentric calcium that's within the plaque, within the kind of circumference of the vessel, and then you can have this real protruding eccentric calcium into the lumen. And I think that's the interesting, does it have the same effect on the big nodule as you would from volume reduction with atherectomy? And I think that's, so I've been using it quite a lot in that situation, particularly in the left main, where I think it's the big advantage of, keeping your two wires very efficient, not having to switch wires back and forward. So I think it's, that in that area with nodular protruding calcium, I've had some really nice anecdotal results, but I think as the research base around that area builds, we're going to get a lot of knowledge about what it does to nodular calcium, and I think that really is going to be interesting. I think this is where the additional use of imaging in these cases is really important for us to understand, not necessarily to affect the immediate decision making and the outcomes of the cases, which obviously it does, but for us to understand exactly what the efficacy of the technology in these niche morphologies are. Now, Carlo, I'd be interested to hear you, because I've obviously seen your data from your registry of eccentric versus concentric, so it'd be interesting to hear you talk about that.
Thank you, Margaret. Yeah, we did have a published single center small experience with the advantage of being only cases done with intravascular imaging in either ultrasound or OCT. I mean, first of all, you can't really say if a lesion is eccentric or concentric only based on geography, because even the original definition that we have used to enroll patients in the DISRUPT trials, so a rail of calcium on both sides of the lesion, you see calcium. Of course, if it's just in one view, it is not paying attention to the orthogonal view, that can be a single 180-degree eccentric plaque. And we had a few of those in the DISRUPT trial that we have analyzed, and Holger has already reported about those. We confirm exactly his data. Only with imaging. So we exactly achieve the same lumen enlargement in eccentric and concentric. My message I received from this is, first of all, concentric are more difficult to expand. So that's the real goal of using intravascular lithotripsy. Second, you can use it for eccentric, but still, I believe we don't have, for that particular indication, we should really run a sort of randomized trial to know whether super high pressure is achieving the same result, because we do see some remaining ellipticity in the lumen or in the eccentric calcified plaques. What now I understand better, we reported in our observation fewer microfracture in the eccentric lesion, and we were surprised we got similar lumen enlargement. Now I know, because it's not good enough OCT to find all the microfractures that are there. At the end of the day, I do use it in eccentric plaques, especially in bifurcation, because when you have, say, a big chunk of calcium in the roof of left main proximal LAD, the only way to expand will be against the circ if you use only high pressure. If you crack the calcium, you will expand also in the opposite direction. And as Margaret pointed out, safely, because you will keep your wire in the circumflex. So I think for that particular indication is an excellent device.
Well, I think it's worth mentioning that there is now, and we'll be starting shortly in the UK, a left main stem shockwave study. This is an investigator-initiated study by James Spratt from St George's. So I think that's going to be quite an exciting study. Certainly we'll gain some very useful insights into imaging within the left main and the difference between the nodular protuberant calcium, concentric calcium, especially around the bifurcation. So I think there's lots and lots of activity now in multiple countries surrounding Shockwave. I think the CAD III data is really going to be seen as a bit of a landmark in the progression of Shockwave, especially in Europe. But I think it's going to, presage the introduction of this as a clinical device in the USA, probably in early 2021. So a question to all of you, and this is really just thinking generally, and I'm going to come to Holger first, and just thinking specifically about CAD III and, DISRUPT CAD III and the whole DISRUPT program. So how will these trial results change the practice of interventional cardiology? How would you sum up what those changes are going to be? Holger, I'll come to you first.
Well, the main topic coming from all CAD I, II, III trials is that the IVL is safe and we have an efficacy to treat calcified lesion. I think that's the main message coming from these trials. And also it's the ease of use, of course. We do not have, as it was mentioned before, we do not have the learning curve at all. You can just set up and you can start to have very nice results coming from the IVL if you treat properly with enough pulses. I think that's also very important to keep in mind that, of course, we have to apply an adequate number of pulses. And this might, of course, change completely our practice in the cath lab because we have now an additional tool. And with this tool, of course, we can reduce also complication. We can reduce paroxysmal myocardial infarction in comparison to other debulking procedures. And I think that are the main topics and messages coming from the CAD trials.
Thank you, Holger. Margaret, what would be your message about how practice is going to change?
So I agree with everything that Holger said there. I think that we now have a very accessible device to modify calcium, which means that calcific disease can be treated by a wider range of interventional cardiologists. So, for example, in our group, maybe half of the operators are comfortable with atherectomy and calcium analysis with imaging. But the other half of the guys now can all use IVL, and they can use balloon expansion to decide whether or not they need it. And if it's in the middle of the night or on the weekend and they're dealing with a 85-year-old STEMI patient who has calcific disease. So I think it really has made calcium modification and treatment more accessible to the wider range of interventional cardiologists. And I think from the studies, what we see, as Holger said, is that it's effective and it's safe and it's used. I think that really, for me, is the bottom line. The other thing I'd like to say from the OCT study, which for me I think is a really important point, is if you adopt imaging as part of your normal practice, it makes your procedures as efficient, if not more efficient, because you have more knowledge. And I think that the time thing with the cases being 58 minutes versus 60 minutes is a really strong argument for you adopting imaging as part of your routine practice, yes, especially when dealing with calcium.
Thank you, Margaret. So Carlo, can I come to you next and just give me your sort of overview of how you think practice is going to change?
Well, I think almost everything has been said. It's safe, it's simple, is effective, has a very short learning curve, is applicable also in STEMI patient in the middle of the night, doesn't necessarily require imaging or other complex tools. I think it's a bigger evolution. It's 15-20% of our patients with an option of achieving an excellent result. I think this has to be considered also when you refer patients to surgery because they have 3-vessel complex calcific lesions. Now, you know that you are achieving a good result relatively simply without shadowing calcium down the vessels and getting no reflow with rotational atherectomy. I think it's a little bit a revolution like for CTO. Before it was 50% success, and now it's 90% success. And the only difference is much easier than CTOs.
Absolutely. Thank you. So lastly, coming to you, Flavio, just give me your sort of overview and how you would see the landscape for calcium modification developing over the next few years.
Yes, I mean, some general concepts. Our population is getting older and older every year. So we will have more and more patients with the calcified lesions. This goes together with age, with diabetes, and with chronic kidney disease. And this is the consequence of the elderly. And so we will have more patients to treat. And I would add another population which is fascinating on my point of view, that is the population with calcified aortic stenosis. the more and more we do TAVI, the more we discover lesions that we would have never seen if not because of the valve intervention. So this is a new population that is considered for vascular treatment without angina, without clear need for treating. But when you are implanting a valve, of course, you put the question whether the left main or the proximal LED might deserve a treatment. And of course, if your treatment will end up in an under-expanded stent, for sure you'd better not do that. Now everything gets much easier because you have a very effective and simple to use device that will allow you to add myocardial reverse to the valve treatment in these patients that, well, now are old and complex and are fragile, but in a landscape that it's rapidly moving to intermediate and low risk. And so I see a rapid growing in the indications and a changing in our type of patients. I mean, studies like ischemia have shown, again, something that was not new, that performing PCI in stable patients is not so necessary if you have good control of symptoms with medical therapy. So these may reflect in a lower number of PCI. I don't think so. It's always a very nice alternative to medicines, but you are doing more diagnostic cases because we improve our cardiovascular care. And most of these non-invasive diagnosis is based on CT scan, and they look for calcium. So the more you look for it, the more you find it. And when you find it, you need to treat it properly. And this is, again, it's a continuously rowing wheel, looking for more patients and finding more patients. So there is definitely a lot of room for development in this specific area of cardiovascular care. And this, as we have said during this conversation today, is probably the easiest way to treat. All the rest has been said. And just to be fair, I would only add a little, probably perceived as a negative word, but it's a word of caution, which is the cost of the device, which is still a little bit too high if we think about the importance it may have to treat our patients. Of course, prices have to do with the number of usage, so I forecast that the more we use it, the more affordable it will become. But in the meantime, it might be a barrier in some small centers.
Yes, I think that's one of the comments that's been brought up in the discussions has centered around the reimbursement issues. But I think you're absolutely right. As we're all getting increased familiarity with how to use it, we all understand it's safe, it's effective. Then as the usage increases, I'm sure that then, you know, that the prices will come down, because I think it will be used at high volume. I was on a discussion earlier today with a US panel, and Samin Sharma was on this panel, and we were just talking about the percentage of cases where calcium modification would be required. And I'd be interested to hear what your views are. But from this American group, so the current number of cases on average where some form of calcium modification is required is less than 5%. And I think Samin Sharma is one of the highest volume rotor operators worldwide. And his prediction, that he was estimating between 10 to 15% of cases, if we're doing the intravascular imaging, we're screening the patients appropriately, we're using our angiographic interpretation skills, that 10 to 15% of PCI overall may require some form of calcium modification. So I think we're at a point now where there's going to be a huge expansion overall, not just in IVL, but in all the other forms of calcium modification, because we're all becoming much more calcium aware. I mean, Flavio, Carlo, in Italy, do you think that 10 to 15% of cases may be using calcium modification? Is that something that's a realistic goal, or is that are we way off that point? Carlo, what do you think?
Well, if you consider how much rotablator has been used or not used, rather, which is right now in the GISE registry in Italy. Definitely, this is not what's happening. But I believe this is also because everybody is like Flavio Ribichini, very confident with rotational asterectomy. I do a few. I just say change the console because, well, we are always the last to get the new console. So, some strange reasons related to tenders. And, you know, I got my issues to just change my normal practice and push pedals instead of buttons. I mean, now we have a very simple device. The only barrier is first convince the people. They start doing the most complex cases. Sometimes they fail because they are super complex. You should always start with normal practice. They start to be convinced when they see stents that don't expand with anything. That's really a unique application of lithotripsy. And then they do more and more, but still is used more as bailout than as routine. If you do routine, I believe the number of Samin Sharma is perfectly correct. 10-15% is probably what you should use. Can we afford it right now? That's another question. Yeah. I think will require some discussion, but as always, when you have bulk use, prices tend to come down.
Okay, I think we're going to have to start to wrap this discussion up. I just really want to thank all these, the panelists here, Carlo, Flavio, Holger, and Margaret. Thank you very much. Fantastic discussions. I want to thank everybody who's tuned in for this webinar. I think the messages that we need to take away, as we've heard so eloquently explained and discussed, is that the IVL technology, Shockwave technology, I think is here to stay. The DISRUPT CAD III study has been an important study that further establishes both the safety and the efficacy of the device. Certainly getting consistent results every time with near 100% stent expansion in almost every case. That's been a lesson from throughout the DISRUPT CAD 1, 2, and 3 studies. We've got I think a very exciting future now for calcium modification. I think Europe has really taken the lead in this regard. You know, we've been driving forward with the Shockwave technology, and I think the interventional community within Europe, I think, is going to be really setting the standards for how we integrate Shockwave into our calcium modification algorithms. So thank you to everybody for joining this webinar. Thank you to the panel, and I'm sure we'll be having discussions in the future about IVL and its multiple applications. Thank you very much.